today on my agenda is that I would like to have some tick points that you could give me that could help me with tools to the scenario I'm going to share with you briefly now, and not at a pitch that my own children come down for.
Yeah.
Yesterday I did a scan of a friend who was dealing with what he said was abdominal pain down in the lower area. And this is an individual that I had identified a compromise in his rectus adductor longus mechanism, or whatever that is down there, that is that classic athletic pubalgia or whatever. And he literally did do well with PRP, or should I say he did well and they put PRP in there, however you want however you want to deal with that. This, however, had him showing me, because he represented it. Oh yeah, it's just like last time. However, this time it was in the fascia to the left side of his. It was above the inguinal canal. It was in what I don't know of any classic hernia weaknesses that are in the abdominal region there. So what I really would like to ask you, because I know you're a hernia type of an imager, if my eyes looked at the tomographic slice and I saw skin, adipose, muscle, and then that bright layer of abdominal fascia before I got to the gut.
Yeah.
If I was just doing general scans looking for something that would say, could he have compromised that? Or should my eyes, or should my mind say, yeah, that's never going to happen. John didn't see it in 25 years of scanning just in a random area of the gut. What you need to look for is the fact that he overexerted his oblique muscles, and so your eyes should be above that white line. So, man, my preambles can get long, John. I just need to have you saying, look, when your eyes are evaluating the cross-sectional area of the gut, you'll know you see a hernia if there is that white line that becomes at all compromised, and when they bear down. Let me just listen to you, because I have dynamic images. I'm embarrassed to share them because it's you. I have dynamic images and below it I have some unique echo texture that I don't know if it's a fecal log or I have no idea. And so I'm trying my best to say, I know someone who's got some pearls in this area. If he can make it seem like I have an accepting friend to show my scans, I don't stop on anything relevant. Anyway, let me listen to you and address. And by the way, I want to spend half this time looking at your random images. So I'm going to make a rule that at 12:30, I'll still be this quiet and I'll be ready to listen to you.
Yeah. Let's have a look. Is that just an image? I think these are just images. Yeah, Spigalian hernias.
Say it again.
Spigalian hernia.
It sounded to me like you said spaghetti and hernias.
Yeah, so almost. Let's have a look. Why don't I share?
Okay, and I think I've already approved you.
Yeah, good.
I'm getting better.
Let's go. Right. How do I move this box?
That must be Mac. That may be difficult for you, John. If you'd have a PC, that would be really obvious. That would be a big one.
Yeah, I bet it could. I wonder. Now there it goes. Share and Spigalian hernia. Oops.
Spigalian.
Yes. I think that's the sort of thing you're referring to.
Yes, that is very close to what At least that's the region that it is. And is this that dynamics where the transverse abdominis has this entry from inside and outside the abdominal fascia? Not transverse abdominis, the rectus abdominis.
I'm trying to think what I would. I've got plenty. I can't believe that I don't have any Spigelian hernias on scan, but they're not coming up on here. Let me just. I'm going to try once more to search this database for it, and it might be that it's faulty again, because I know I've got some Spigelian hernias. No, I haven't. I tell a lie. Let's go inguinal. Yeah. Oh no, that's not. This is not doing well. Yeah. I am going to have to do some work on this. Right. This has to be better searchable because I have lots and lots and lots of images.
Let's just forget it until next week, John. I don't worry about it.
Can you share your images?
I can try. And let me see if I can do that really quick.
I stop sharing.
First, you need to remember that it's me and my images are.
That's right.
Let me try to pull it up from my. There we go, and I'll download these to a file. And when I say images, I have not done any still shots on this because I wouldn't know what to still shot on. So these are going to be a bunch of dynamic scans. And let me see whether or not I can go back to share. Here we go. I'm going to let me try and share that. If I go up to, nope, I want to share something different. I'm going to go to here. All right. I don't know if you can see this, John. Are you able to see a list of things that say capture on here?
Yeah, that's the one.
All right. I'm going to try to increase. I don't know if you're able to see my management of them. Are they a little bit bigger? I was hoping to actually have an icon so that you wouldn't have to waste through any of these, but I'm just going to randomly start this. Yeah. I'm going to see whether or not. Do you still have this? I doubt it. Let me back out. I'm going to stop sharing. I'm going to go back to share. Don't know why. For some reason, as soon as it comes up, I lose my share. And yeah. I'll try one more time, and then I'm going to just tell you that. Let's see. If I take it to here, minimize this. You're not seeing anything. Ah, here we go. You probably will be able to see this now. So my mind is seeing this in long axis of abdominal muscles. I don't know where we're oriented, so I see this down here at the lower part of being gut material down in here, and that the skin is up here. This is fatty reflex, and I'm getting down to the end. To the left is distal. Probably should be proximal, but anyway, this is it. Would my eyes be? I guess that's what I don't know. I don't know. I know this stuff. I know this stuff to be kind of a poopy, fluidy junk. But is this line relevant to your eyes as I'm scanning that? So let me pull up another one, because I know I found something underneath this. But what I was saying to myself was, this line needs to somehow be compromised, and there should be some fluid or something up in here if there's something. And if he bears down or blows on the back of his hand or whatever, it would be good to see that fluid or that junk go up and down. Let me see if I can undo this and go back to see if I can't share a different one with you. And again, I'm promising because I want to learn from your images, not just you wallowing through me being unprepared to talk to you today. Let me see here. If I go back to, I'm going to go to here. I'm going to go to this one and see whether or not. Seems to me that if I now go out of share and then come back into share, I can have us both see that. Yeah, here. So I don't know what this thing is showing up like here.
Yeah. And that's now inside the abdomen.
Okay. So that bowel, I'm trying to, anytime I'm looking, I'm going to try to stop this. Anytime I'm looking here, and there has not been any compromise in this white plane here, I can say that this is just incidental fecal feces or something in some form of.
Hold a second. I'm going to try and do something, but just bear with me. I'm going to go. Right. I'm just looking at Shift Command 3. I'm just going to go. Shift Command 3. Okay. Yeah.
By the way, buddy, what a fun time. I shared the picture of all of your family with my wife, and we enjoyed every one of them. You are so incredibly rich as a fella, from that absolutely stately older girl to your youngest boy that I just want to give a big bear hug to. You just really have a charming family.
Thank you very much. My computer is not as clever as I thought it was. I have just, or at least I've just done something crazy. So I'm going to have to kill that program.
Let me give it back to you then.
Yeah, just hang on, wait a minute. Could you go back to sharing that screen?
I can try. Let's try that.
Yeah. Now, again, just where you were before, about 2/3 of the way through. Yeah, about there. So you can stop it about there. Yeah, just stop it there. And what I'm gonna try to do is, and what I tried to do just before was to Shift Command 3. Yeah, good. Now I'm going to try put that there. Okay. And now if you let me share.
Okay.
I'm going to see if I can. This is a bit clunky, but there we go. Excellent. Let's see if we can just make that bigger and go there. It's a bit of a clunky way of doing it, but now I've got my arrow on your picture.
Yes.
Okay, so you were dead right about fat, abdominal wall. This is the peritoneal cavity. So this is where all your guts are. And this is a long section of bowel, with this being the bowel wall, and this is poo.
Okay.
And this is
when we say bowel, we do mean the small intestines, or do we say that this is the colon?
The colon and the small intestine, mostly you're looking at the small intestine. The colon has a very, if you go, we get a picture of the small colon. Let's get a picture up. Yeah, that'll do. And this one. Yeah. You see the colon in 3 specific places.
Oh, okay.
You see it next, coming up from where everyone has their appendix scar.
Yes.
Up the side of the kidney, by the side of the kidney.
Okay.
And then it drops in front of the pancreas here. And then it touches, basically bumps into the spleen, comes down the other kidney there. Everything else in the middle is small bowel.
All right.
So, and this is a big tube, and you generally see it full of air. So that wide caliber thing with lots of just air noise, where you only see a very fine bit of bowel and then lots and lots of noise, lots and lots of rubbish picture underneath, which is air artifact, is typically the colon coming round here.
Okay.
Everything else, everything that you see in your slide here,
yes.
is that's this sort of caliber and shrinking, and you'll often see it sort of going up and down like this, particularly if they've just eaten. And in slimmer people, you'll see it a lot. In larger people, then you've actually got it there, but it's often buried under this, which is what's called omental fat. So it's the layers for your own good that are stuck to the bowel, like a skirt.
Yeah.
It hangs the bowel is like a ribbon, and there's the skirt of fat that just multiplies and multiplies.
Wow.
So that's what you're looking at there. So
that word that sounded like spaghetti and ended with hernia, was that because, is that nuance that is between where the rectus abdominis has parts that are in or outside and inside that white line that you were showing me before? Is there a compromise of bowel, or I guess what I'm saying is there any type of general pearls you can say, my eyes look here, and as long as this is here, or anything like that? Or
for some reason, as usual, my computer is not searching my external hard drive, which I haven't solved. I thought I had, but I'll just ultrasound. I'll just search online ultrasound.
Let me ask you this: if you were to find a terabyte, what do you call that? RAM disk that you could dump all this stuff onto. Would that assure us that we would have access to something?
No, I've got it. I bought it. Okay. Lovely thing. It's called a T7. It's so fast. Okay. For some reason, I have to do something to it.
Okay.
To make my Mac search it properly. Where is it? I was hoping someone would have a nice video on there of transversus abdominis, because that. Oh, we can turn that off. Scanning. Right, are they going to? I'm just going to see if they've got. This is all stuff you're very familiar with. I'm hoping somewhere in the video they've got a picture of it at the end. No, they haven't. Okay, are you familiar with transverse abdominis?
Yep.
Okay, so if I stop that, so there, when you get to the end of this, and you come to the rectus, you've got your 3 layers of muscle, and then you've got your rectus sitting like that.
Yes, yes.
These fibers fold, like the fibers sort of cross over and go round the rectus.
Yes, okay, I'm with you.
In that, and you can follow that line right up the tummy. Yeah, so you can follow, when you follow rectus, there's a line of fascia. You've got the line of fascia in the middle.
Yes.
And you've got line of fascia between the rectus and the thing. Now, typically just above the inguinal line, but really anywhere where there's been any surgery, that can then become weakened, and you can herniate, and people herniate into that.
Now, you had done a qualification of saying surgery. What if this guy is just very deconditioned for a period of time?
Just much less common. It's normally there's been some sort of, someone's made a cut through there to weaken it. But and I have got a video that shows something like that. Where have I got it? Where did I do my search? Yeah, I think. No, that's not it. That is, let me go back to here. Somewhere I just did search. So let's go search hernia. And if we go film. So here there is this. So, and that's not it. So I may have already shown it to you, but if I go to the top, that's a indirect. Okay, yeah. So this is, can you see that?
I can see the image.
Yeah.
Yes. Now ooh la la.
Yeah, so this
Can
is.
you orient me to the fibers that are down? Is that the rectus on the right that you're over right now?
Yeah, that's the left rectus abdominis.
Oh, this is
And
then through the.
This is actually at the linea alba, but
Yeah,
that's
yeah.
what you see. And it doesn't actually protrude through the superficial fascia. So it's actually going over the muscle, but staying within the tummy wall. And that is very typical of a Spigelian hernia.
Only it's on the other side. The Spigelian is on the other side of the rectus.
On the other side, yeah. And it tends to bulge out more. It doesn't normally slip over the rectus, because that's usually quite a strong fascial attachment. This is postpartum, I think. Lady who's had a hernia there. But that's what you would be looking for. That's the other type of non-midline. There are lots of midline hernias. And you've got your classic inguinal hernias. But if you come up the wall, what you get there, let's say normally, it doesn't have to be associated with surgery, but is usually, that's the thing that makes, because it's a pretty strong part of the body.
Yeah.
The midline gets into trouble because there's, when people get bigger, that's the give point.
Right.
The sides, there's not the strain there to cause it. There isn't a natural weak point there, but you've got all these crossing of fibers, and sometimes you've got a weakness there, and people herniate through, and they get hernias. But they're normally, because it's multi-layered, they rarely go all, unless they are big surgical, unless they're properly surgical problems. They normally don't go all the way through into the subcutaneous layer. They're normally contained within the different layers of the abdominal wall.
So by definition, to have it be an actual hernia, there needs to be some structural element that occurs, that comes from the under tissue, the gut material, and it compromises that fascial layer, and maybe not compromises the fascial layer, but goes through a weakened spot and erupts into the area above that. And if I then were to be certain that I have scanned the region looking at that fascial abdominal fascia or whatever below the muscle layers in various angles, under loads, if there were a hernia actively herniating, I should see something that breaks the plane of that white line somehow. So the last thing then I want to ask is, how often or how evident do you think a person would be able to identify compromised oblique muscles, meaning that there was a focal internal oblique muscle tear? I guess that's about as difficult to see as a gastroc tear or a quad tear, at least in the mid fibers. The likelihood of that is pretty low, right?
I've probably only seen one.
Okay.
Get one medial internal oblique injury, as opposed to some form of sharp penetrating injury.
Yeah.
In the internal oblique. So yeah, I in my population, not a common finding.
I am now ready to be the student here and be in awe of. Or not, I don't want to set you up for anything, but yeah. By the way, I've got my birds descending on my suet, so give me just about 30 seconds to shoot something here. Okay. I've taken to just scaring them because, well, we're becoming a kinder and gentler country as of yesterday, and so we're
Mom, I got my gun.
Right. All right.
Let's have a look at some stuff. So this patient had carpal tunnel syndrome symptoms. They didn't have carpal tunnel syndrome, but they didn't have, the nerve looked normal, but the actual flexor tendons did not look normal.
Oh, and this is
extensive synovitis.
Oh,
and it's just, your eye won't, the thing is, your eye won't see it, or my eye doesn't see it automatically, because this appearance is normal in the muscular part. That just looks to me like muscle around the tendons, which is what you see above the carpal tunnel, up in the proximal to the wrist. And so then these are
the contractile components of the flexor tendon muscle that's growing toward the carpal tunnel.
No. That's what my eye sees when I first go over there. I see these as the tendons and this is the muscle.
Yeah.
But that's what you would see if you were here.
Yes.
But when you are in the hand, which is where we are now, this is synovitis. And it's something that you get fooled by, because you're scanning through the carpal tunnel. You're scanning the carpal tunnel. You're looking at the median nerve here.
Yeah.
And then as you go through, something just thinks, and then you remember that you're not meant to see lots of low echo once you get into the hand. But your eye won't pick it up, or my eye doesn't pick it up straight away, because I'm so used to seeing that just proximal when you're still in the muscles.
So would you say, many sessions ago, you had talked about enlarged synovium, and that would you be able to say this has been an irritation of long standings because of how elaborate the synovium is, or could this be something that's just a overuse inflammatory response?
This is systemic inflammatory response.
Okay.
This is wild. It's going all the way down the fingers.
My land. If I was not mistaken, you went all the way from above the transcarpal ligament all the way through the hand and then down one of the fingers. Is that?
Yeah. Yes, I'm just following it through.
Wow.
I'll stitch that, and then there it is in long section. And you have to be paying attention to notice that. Surprisingly, it's really obvious when you're shown it, but when you're scanning and you're not expecting to see it, you have to you have to force your mind to pick things up like that, which is why I show it.
Are you also quite happy with the sensitivity of your color Doppler in that, or would you say I'm using a standard imaging tool, so any decent machine would show it that brilliantly?
No, you have to make sure that your gain and your pulse repetition frequency, your scale, are set appropriately, and that's machine by machine. But as a yardstick on all the machines that you can adjust it on, I say that if you're down at 3 centimeters per second, which is the measure they use for it, then you're doing quite well, and you should be able to see stuff. But there's stuff that works in the background that isn't easily adjustable, that makes a difference. And there are some what's called wall filters, and sort of various filters that they use that have to be set up right. But if you've got a standard musculoskeletal setting on your machine, and you bring the pulse repetition frequency, or sometimes called the scale, down below 5 centimeters per second, then you're usually in the right ballpark.
I can't adjust that. I can just adjust the gain. So I don't know what's happening, and I can only assume that they're trying to say, look, this is just for the most glaring of problems when it comes to that.
Yeah, well, but you, if you're putting color on things regularly, you'll get to learn. If your kit's reasonably sensitive, if when you see an Achilles or something like that, or a tennis elbow, a good machine, this machine will generally show some color flow, even in the most tame tennis elbows.
Okay.
So that's a reasonable yardstick.
Can you take me back to the inlet of the carpal tunnel and tell me whether or not your eyes saw that as overly convex compared to a normal transcarpal ligament? Right there. As you view that, did something in your mind go, whoa, that's already big? Or is that a common finding with it that dome-like?
Well, it's swollen, isn't it? I think there. The whole region swollen. To be honest, I don't really look too hard at that. I look at the content. People write about it, but I tend to look at the nerve. That's what I care about most.
Yes.
It's the shape of the nerve.
Yes.
And I'm not even sure that's as reliable as they make out, but it's usually, it should offend me. But what I do is I watch the nerve as it comes from proximal. And does it swell up as it approaches the tunnel? Does it get bigger?
Does it have a muffin top, or does it bulge on the proximal end of the nerve before it tightens its pants? And with the all right, and so that's what you're looking for, is this little blip of going from big to small as it goes under the tunnel.
More that's big to small, but mostly normal to big is what I find. Thing. And then checking, because sometimes it looks relatively normal coming into the tunnel, and it's actually when it comes out of the tunnel that it seems to be abnormal.
On the distal end.
Yeah. So once you come out from the area of compression, sometimes then it suddenly swells up, and that seems to be a less common, but potentially equally valid variant.
Wow.
So that was my synovitis, unexpected synovitis in the tunnel. I've talked about this one before, and you just sometimes, and I keep seeing it, and I don't really know what the relevance is, but I look at the coracohumeral ligament, and it just happens that on this case, on the affected side, this is the abnormal one, tight. It doesn't look that thick, but this gentleman had a stiff shoulder, What I want you to see is what happens as it goes over the coracoid. So this is the coracoid process.
Yes.
This is the coracohumeral ligament.
Yes.
But it doesn't get to the coracohumeral ligament and stop. It carries on over the top. And
how far down from the tip of the coracoid are you en route to where you...
Quite far down. It's almost as far down as you can go and still see.
So you are not halfway to the clavicle. You're actually like bumping right up against it.
Sometimes it is variable.
See, I'll tell you what you need. No. I'll tell you what I need. I need a sono hack on this exact spot. And so the next time you have like the perfect patient, and this would have been one of them, I want to see that. I want to find that. Would I find that? And that, what are you doing? Is that you're rotating the humerus?
I'm scanning up here at a slightly odd angle. So you don't get a good view of the humerus at this angle.
Yeah.
But you get a good view of the coracoid.
So I've tried to use your words on every time I scan this, and I look for the coracoacromial ligament. And then once I identify the coracoacromial ligament, I push myself posterior or more and more proximal on the neck of the coracoid, and I begin to diagonally lower the beam toward the head of the humerus, trying to look for this. But that's what I need to have. Is I need to have somebody videoing you do that.
Yeah, I think the trick is just to scan the coracoid.
So tell me again, you're simply going short axis on the coracoid, looking for this hat.
And then you're looking for, and you scan along it like this.
Yeah.
And if you have a suitable patient, and once you've seen it, you get an eye for the angle, and you'll see that there's another bundle of fibers coming off here, and you have to do it quite slowly. So you've got to because it can be very, very faint, and you have to optimize the picture. But you'll see this band that is not the coracoacromial ligament, which goes that way and is easy to scan, but this one that pitches down.
I want to do that, and I'm going to send a good one to you so that you go, good job, Greg.
Yeah. but when I sort of saw this, and I thought, well, I'll compare to the other side, because I think there's a bit of bullshit there, and so this is on the other side, and he's actually got a thickened coracohumeral ligament on the other side as well, but he's got this variant whose significance I'm not sure of, because if you look, the tendon is continuous with the tendon of the ligament is continuous with the tendon of pec minor.
Oh, how do your eyes even see that, you crazy man?
Once you look for it,
yes,
on an easy patient, you will see it, and then you will always recognize it.
Wow.
But it's not attached. On the other side, his is not firmly attached. If you look at the movement, so his pec minor attaches into his coracohumeral ligament and it's dynamic.
Using the coracoid as a pulley-like system.
Yeah, almost. But when you go back to the other side, you see that as you move it, that is attached. So this is a variant, and these are two forms of that variant. On one side, they are contiguous but attached to fixed at the coracoid. On his other side, he is.
What a treat to have you show me these, man.
And I would love to be able to say that I can give you some clinical relevance for that, but I cannot. I just see it, and I think somewhere, at some stage in the development of shoulders, that's got to be something of interest to somebody. But
John, you're not going to share this on the MSK group and come up with your own efforts to get a bunch of comments from everyone around the world. I mean, that's worth sharing there.
I put that out there, but people aren't looking at it, so they don't.
Where are you doing these things? Because
I'm sure I put something out on Twitter about it a couple of years ago.
Oh, a couple of years ago.
Yeah, but people aren't looking and there's no clinical relevance, so no one's going to. People don't find it hard to see that anyway. So
yeah.
And then if it's not that important, it's a hard one to justify. I've been looking. This is the capsule, the inferior capsule here of a patient, and that's on the normal side. So normal side and thickened, and again, this is one of those stiff shoulders.
Okay, now I need to see if I need to get my head around this. This is the capsular fascia or tissue that is located under the rotator cuff tendons in the area.
This is in the armpit.
Oh.
And you can't see it on every stiff shoulder, but you can.
How are you doing this now? You're taking their hand over their head and you're coming at it in the axillary area posteriorly, or are you just trying to find the head of the humerus and
No, I literally in the armpit. I've been trying it for a while, not having much success, and then the boys on your on that video of yours said they get the patient to put their hand there, and actually that helps, because I've been holding the arm up and doing this and not getting anywhere. But when they put their hand there, you get a little bit more range on it.
So then talk me through this again. This is part of collaborating a adhesive capsulitis. Is that what you're doing?
Yeah. When if I don't see any thickening on the coracohumeral ligament, then I have a look. If they can get their arm up high enough to be able to touch there, then you can usually get to see the underside of the thing. And then that's the capsule there, and this is it here, and you just see that thicker than this, and you go, I think that's a frozen joke. I think that makes the call.
And then you put 1 liter in the capsule and blow the thing out so you hear a pop, so that your arm can go up and over your head after that.
That's so much bollocks. It's very lucrative bollocks, but it is bollocks.
but what do you then say to the patient? This is just going to be another 3 to 6 months, and it will resolve itself, or are you saying what you don't want to do is how do you manage this? Do you say I can inject it and reduce the pain?
Yep, I inject it. I do a small stretch. I don't use the big volumes that people do, because there's no evidence that popping the capsule helps. It doesn't stretch it anymore. So I put in between 11 and 20 mils is all I put in. So I don't put in a huge volume, but I do enough to stretch it.
Where do you do it?
I just a standard glenohumeral joint injection, which I put into the back. So if we do, I must have a video on here somewhere. The glenohumeral joint, shoulder injection. I don't know if this is a good one or not, but so can you see where you are?
Yes.
So this is the glenoid.
Yes.
This is the labrum here. That's the humeral head. And this is probably teres minor, because that's normally where I target. And you should be seeing a needle coming down here. This one's a little bit high. I'll move on. Let me try another one. Where the needle's a little bit more obvious, yeah?
Yes.
Okay. So the needle pops just into the joint there. And then if we just have a look, find a position there, it's going in. You just see a little bit of fluid going in. And in a moment, I'm just trying to get the right place. So there, and there, do you see the capsule starting to stretch?
Whoa, yeah. What is that big flash?
That's probably, it may be a bit of steroid going in, or it might be that I didn't flush all the air out.
Oh.
So there might be just a tiny bit of air, as I just put the last bit in. Let's have a look on this one. So see if we get a slightly better stretch on the capsule here.
That is so amazing.
Yeah, there. Do you see it as it
Yes,
tightens up?
yes.
And that's only after about 6 mils. So you actually get the stretch quite early on.
Let me ask you a candid question. When you are doing these imaging, what percent of the time do you feel you have the actual needle imaged?
Yeah, with these every time. You're seeing the tip of the needle.
Yes.
In here. Even these are quite deep injections, relatively speaking. They're down at 4 centimeters, so it's quite a steep approach. But when you come down there, you see the needle there.
Yeah, absolutely. I've just been with some guys sometimes in their labs that are supposed to be really quite adept at doing this, and I've watched them be quite challenged with identifying the plane of the needle. And I know that if you're doing this by yourself in the room with the patient, there's the nuances of soft tissue movement. There's just in and out of echoes. You just don't commonly see this perfect white line that goes from the outside all the way down to where it's delivering its goods.
Yeah, and sometimes that's slightly imperfect technique. Sometimes you can't have, because of the way the image is built, you don't always. It's not always optimal to see you're not getting the right angle on it to see all the way down the image throughout, but you do need to see the tip. And on these, some days I'll do 3 or 4 just of this injection. So I tend to do them in my sleep, but you should always have. So I just go look injection. If you look at, just search for injection. There, let's see what we've got. So I do a few injections. So, if we go, let's see what we've got. Trochanteric bursa injection. See, trochanteric bursa injection is another deep injection. So
I'd love to see that.
So the question is whether I saw the need. So this is one of the ones where it can be tricky. So I'll say that because I haven't pre-reviewed these, so I don't know what I'm showing you. I'll drag this along, I think.
Okay, I can see tissue responding to at least the friction of a needle going in.
Okay. So yes, so when you get down 3 or 4 centimeters, it can be tricky to see the needle tip, but hopefully when I deliver the medication, you should. Yeah, so I can see it going there. I'm not seeing the tip perfectly in that one. But
one does not have to see the tip if we start to see a distance developing under the fascial layer that we're looking to apply the injectate, right?
Yeah, I think you'd have to be very careful to take that view. I should see the needle in almost every case. In the real world, if I'm absolutely sure that it's that I'm in where it is, then I might. But I would certainly not be letting my students. That's which one's that? That's a Morton's injection or a Perry-Morton's injection.
And so what are you putting in? Saline, or is it corticosteroid too?
A little bit of corticosteroid, just into the tissue around it. And
boy, I could have you edify a Morton's on a session just to get that so rarely. That is this an ACJ or?
Let me just these haven't been edited properly, so these are ones I can't show. Let's have a look. Yeah, some of them are historic, and I need to go back and edit them better. Let's have a look. Glenn Hugo, subacromial. You've seen lots of subacromial ones, I presume.
I'll see whatever you want to show me, man.
Look. So this is, ankle joints are a bit tricky. So you often have to go over these osteophytes. So here I am coming in.
What tendon is that? The peroneal tendons, or is that the posterior tib?
This is probably tibialis anterior.
Okay.
And so I've decided this is a particularly tricky ankle joint. So I've gone in under tibialis anterior in that axis. So, and I'm going to rest it.
You're going to place it above the talus then, as far as, yeah, okay.
Yeah, so there I've just gone in above the talus, which is not my standard approach at all. But like I said, I've not gone in and edited these tricky to tendinosis. I'm just trying to think. Subacromial injection. Quervins is always a cute one, but you should, on all but the really deep ones, you should see the needle really beautifully. And then on some of the deep ones, there is some compromise. But if you're going into tiger country, if you're going anywhere risky, then you really should work a bit harder. And
but in order to see the needle, you have to actually have that slice thickness perfectly in line and following that needle quite precisely. Correct? I mean, if you wag it or if you're out of plane at all, like right there.
Yeah.
Where this is the decurve vein?
Yes. So there, I'm just working. I'm actually got the needle in the tendon, which is not what you want. But so long as you don't inject at that point, and then but I'm working it round so that I make sure I fill it up. In some of the chronic ones, you don't have very much. There's not much synovium to get the thing into. Let me just.
Why don't you want to inject into it? Is it a restriction on how hard you have to push, or is it because of the capillary action of pushing up the fibers, or is it just not delivering it into the sheath like you would like?
Well, you want to go into the sheath. You don't want to disrupt the tendon. Not with corticosteroid and local anesthetic. They're not good for tendons. Even if injecting, you basically, if you inject into a tendon, you basically dissect the tendon.
Okay.
So it's I don't think it's really very good unless you're deliberately. I know I don't do very many of them, but I know John Jacobson likes to do quite a lot of sort of essentially dry needling.
Yes.
And certainly in the past, we used to do that sometimes with the plantar fascia with some steroid. So we'd needle it and be applying sort of really microscopic doses through into the steroid. This is just coming into a trigger thumb, so around there. This is that. So I'm injecting around there. But I'm actually too close nowadays. Even just I've changed my technique a little bit. So this is right up at the pulley, and I used to try and inject between the tendon and the pulley, which is actually really hard work. If I get a more modern version of that, I go a little bit more distal now. And
were you attempting to gain some laxity or slackness in the pulley by doing that?
I think that was just the way we did it. That's just where the pathology was. So you targeted that, and you knew there was a plane there, so you try and push it in. Now I'm sensible. It's hard work doing that, so I come back a little bit and I try and aim for the synovial sheath just around it. But we all make stuff up as we go along, and and you just modify. You do things. You get tired of it being difficult, and you think, and you try and think of why it has to be that way, and then you go through. So this is the approach I use for the AC joint. So I get the AC joint in long section.
When you say AC joint in long section, it means to me that you are doing your slice width is actually in short section over the AC joint, and you're bringing the needle in long axis with that slice width.
Yeah, I don't think there's a good set of words for that, but I'm in the sagittal plane of the body.
Yes.
So I'm taking the slice of the joint.
Yes.
And I do quite a lot of these, but they're quite nice. And you see there, I've missed, so I've gone too high, so I can reposition my needle, and then if I'm in the right place, then the fluid goes in very nicely, and you just see the whole joint swell up.
Really cool. I want to be you. Now, I need you to go and give a hug to my buddy Alex and James and those guys before your wife doesn't let you talk to me anymore.
Well, that's always a possibility.
And just a second, right. I forgot my spunky girl, little girl, Florence. Yes. Florence, and then there's Beth.
Yes.
Good.
We've got the full lot. I don't think there's I do lots of frozen shoulder injections and glenohumeral joint injections of all different varieties. And then the other ones are all much less common.
But by frozen shoulder, are you saying that you do a lot of frozen shoulder injections, and by saying that, that's what's on the queue? Or is it that after you've done your diagnostic looking at the coracohumeral ligament and now looking at the synovial fold, you say, this is a frozen shoulder, so I'm doing an injection? What categorizes it as a frozen shoulder?
Well, they come in clinically as a frozen shoulder.
Where they have limitation in?
Yeah, limitation. Or a lot of them come in as impingement. And then when you actually look at them, you go, that's all I put my hand firmly on, I just place my hand on the patient's shoulder just as I'm starting. I look at their external rotation, and then I just lift the arm up with my hand there. And if they don't get up there, then I'm very suspicious. It's either arthritis or a frozen shoulder.
And the difference is that one you would focus to the actual glenohumeral joint, and the other one you would focus to the subacromial subdeltoid bursal region.
Yeah,
that's fabulous.
If you're going to if it's an impingement type thing, then your first bet is typically that you want to do a subacromial injection to just numb off the bursa and see if that frees things up. But if they're stiff, if it's sore, if the pain is much more in the reproducible in the lower range, before you get to the point where the bursa becomes irritated, or there's the tendons become irritated, then you think this is glenohumeral joint, and then then all that really matters is if you think it's more arthritis. I won't necessarily use any volume. So I will just use 3 or 4 mils of lidocaine and the usual dose of steroids. And then if I think it's a frozen shoulder, then I give it a little bit of a stretch as well. Do I think the stretch is helpful? I'm not convinced it's hugely helpful. But I want to see the capsule stretch and expand at 6 to 8 mils. So after a relatively small, by the standards of the people who are doing the large volume hydrodistensions, I'm putting in relatively small amount, but I'm putting in enough that if it is a frozen shoulder, I can see it fill up and tighten. So if you take your finger off the syringe will push, the fluid will push back into the syringe, even after you put in 7 or 8 mils. And then you say, well, the shoulder capsule in a non-frozen shoulder is much more capacious than that. And so it sort of helps with your differential.
Yeah.
And then you say, so in those ones where it's a bit ambiguous, you go, actually, you have a tight capsule and you get some immediate pain relief from the injection. We weren't sure, but I think I'm now pretty sure this is a primarily a classical capsulitis.
Very cool, buddy.
Yeah.
Let's see if we can connect again next week. And
probably not next week. I've got a what's the name meeting. There's some sort of physiotherapy meeting that night. But
we'll leapfrog over that, and then make sure and connect me with any of those debriefings that you do with your colleagues over there too.
I was thinking about doing one. I was using you as a showing you some scans, see which ones were sounding interesting when I talk about them. But we'll do that maybe next week. Maybe Tuesday next week.
Sounds good. Keep me in the loop, and we'll stay in touch.
Cool. I'll
see you later. Take care, friend. Talk to you later.
Bye-bye.